When a patient goes into respiratory failure, you are essentially solving one of two mechanical problems. You are either failing to get oxygen into the blood, or you are failing to clear carbon dioxide out of it. This diagram illustrates the distinction at the alveolar level. On the left, we see a gas exchange issue. Oxygen molecules are blocked by fluid or collapse, struggling to cross into the capillary. This is hypoxemia. On the right, the alveolus is physically overwhelmed, dense with trapped CO2 because the lungs aren't moving enough air to flush it out. This is hypercapnia. To fix the failure, you have to name it accurately. The specific microscopic derangement completely dictates which machine you bring to the bedside. Looking at this matrix, we map the two primary tools directly to the two failures. Type 1, hypoxemic failure, points directly to high-flow nasal cannula. Type 2, hypercapnic failure, demands the mechanical pumping power of a BiPAP machine. Applying an oxygenation tool to a ventilation problem fails to clear the acid from their blood, and it can create a false sense of security by propping up their oxygen saturation while they quietly deteriorate. Let's start with a standard hypoxemic case. A patient comes in with pneumonia. Their SpO2 is dropping, but an arterial blood gas shows their CO2 level is completely normal. Because the ventilation is intact, we reach for the high-flow nasal cannula. This airway cross-section shows exactly how high flow tackles the problem. First, it flushes stagnant dead space out of the upper airway, ensuring every breath drawn is rich in fresh oxygen. Second, it delivers 40 to 60 liters of flow per minute, easily meeting the patient's peak inspiratory demand. Finally, that constant flow provides 2 to 5 centimeters of continuous positive airway pressure, or PEEP, splinting the airways open. And because the air is heated and humidified, the patient remains comfortable enough to talk and eat. But notice what the high flow doesn't do. It doesn't physically push bulk air into the lungs. It is an optimization tool for oxygenation, not a true ventilatory pump. Now consider an acute hypercapnic patient. A COPD exacerbation presents with a low pH and dangerously high CO2. Oxygen alone won't fix the acidosis. We need to physically force more air in and out to clear the trapped gas. We need BiPAP. This waveform visualizes the mechanics of BiPAP, delivering two distinct pressures. The baseline is the expiratory positive airway pressure, or EPAP, which holds the alveoli open between breaths to maintain oxygenation. During a breath, the machine steps up to the inspiratory positive airway pressure, or IPAP, forcing a larger volume of air into the lungs. The real work of breathing happens in the space between those two lines. This highlighted gap is the pressure support. A wider gap pushes a larger tidal volume, moving more air and clearing more CO2. This creates a common mechanical trap at the bedside. If a patient's oxygen drops and you raise the EPAP baseline without touching the IPAP peak, the pressure support bracket shrinks. You might recruit alveoli, but you have just reduced their tidal volume, meaning they will retain even more CO2. Operating a BiPAP requires moving both pressures in tandem. When you adjust the baseline for oxygenation, you must maintain the gap to preserve the machine's ventilatory power. When a patient is severely acidotic, adjusting the pressure gap shouldn't be a guessing game. You can calculate exactly how much extra air they need per minute to clear the CO2. This equation calculates the target. Desired minute ventilation equals the current minute ventilation multiplied by the current CO2 divided by the target CO2. Let's look at an active scenario. If your patient is moving 8 liters per minute with a dangerously high CO2 of 60, and you want to bring that down to 40, how much air do you need to move? Plugging in those values gives us a target of 12 liters per minute. To hit our goal, we need a 50% increase in total minute ventilation, achieved first by raising the rate, then the tidal volume. Using this math grounds your bedside decisions. You stop turning knobs based on intuition and start engineering a specific physiological outcome. Acute crashes are one problem, but chronic failure behaves differently. Take a patient with obesity hypoventilation syndrome. As they fall asleep, their physical breathing effort wanes. If they are on a fixed pressure BiPAP, their tidal volumes will progressively shrink over the night as their respiratory drive weakens, leading to dangerous CO2 retention. This is where AVAPS becomes highly effective. Average volume assured pressure support ignores fixed pressures entirely. Instead, you program a target tidal volume based on the patient's ideal body weight, and the machine handles the rest. This visualization compares the two approaches. On the left, a fixed BiPAP pressure results in shrinking lung volumes as the patient tires. On the right, we see the AVAPS logic at work. As the patient's physical effort drops, the machine automatically stair-steps the inspiratory pressure upward, dynamically adapting to guarantee that every single breath hits the target volume. AVAPS evaluates moving averages, meaning it responds too slowly for a sudden acute crash. But for chronic hypercapnic patients who progressively exhaust their respiratory muscles overnight, it ensures their ventilation never falters. Let's test these mechanical rules against clinical reality. If a patient presents with flash pulmonary edema, they need the heavy lifting of a BiPAP to simultaneously push fluid out with EPAP and ventilate with IPAP. If a patient on non-invasive support suddenly drops their oxygen saturation, you raise the baseline EPAP to recruit alveoli, but you must simultaneously push the IPAP up to preserve the pressure support gap. None of these tools are substitutes for securing an airway in a deteriorating patient. If you start non-invasive support and do not see a drop in respiratory rate, a decrease in accessory muscle use, or clearing mental status within 30 to 60 minutes, the therapy is failing. Do not delay. Escalate to intubation. This graphic summarizes the core logic. Hypoxemia points to high flow, hypercapnia points to BiPAP. Remember that IPAP controls your ventilation and clears the carbon dioxide, while EPAP controls your oxygenation and recruits alveoli. And when chronic effort fluctuates, AVAPS secures a fixed volume. By naming the specific physiological failure and mathematically matching it to the right machine, you stop simply reacting to a patient's distress. You precisely engineer its reversal.